Hello everybody, this is Ana Abdullah speaking. Hope you and your families are well during the second wave of COVID-19. Today we'll talk about an antimycobacterial drugs. Mycobacteria is resistant to most antibiotics due to three reasons. Reason number one, they grow slowly than other bacteria, so antibiotics that are active against rapidly growing cells are relatively ineffective. Number two, mycobacterial cell can be dormant and thus resistant to many drugs or killed only very slowly. Number three, the lipid-rich mycobacterial cell wall is impermeable to many agents. Due to these three reasons, combination of two or more drugs are required to overcome these obstacles and to prevent an emergence of resistance during the course of therapy. The response of mycobacterial infection to chemotherapy is slow, and treatment must be administered for months to years depending on which drug used. This table informs us about the two line agents used for an antimicrobial for the treatment of a TB. The first line agent, which include isoniazid, rifampin, pyrazinamide, and ethambutol. The second line agent, which include many drugs of them, micacin, scabriomycin, cycloserine, thionamide, levofloxacin, moxifloxacin, and others. We will start with the first line agent. Number one is isoniazid. Is active for a treatment of a TB caused by a susceptible organism. Small molecule, molecular weight 137, freely soluble in water, less effective against non-tuberculous mycobacteria. Isoniazid penetrates a macrophage and is active against both extracellular and intracellular organisms. Mechanism of action of isoniazid inhibits the synthesis of mycolic acid, which is essential for all components of mycobacterial cell wall. Isoniazid is prodrug activated by CAT-J, mycobacterial catalase peroxidase. Then the activated form of isoniazid form covalent complex with an acyl carrier protein and Cas-A, which is beta ketoacyl carrier protein synthetase enzyme. Then this complex block mycolic acid synthesis. Pharmacokinetic profile of isoniazid absorbed from a GIT on empty stomach, when peak concentration decreased up to 50% when taken with a fatty meal. The concentration in a CNS and a cerebrospinal fluid range from 20 to 100% of simultaneous serum concentration. الميتابوليزم of isoniazid by acetylation by liver N-acetyl transferase is genetically determined. So, an average of plasma concentration of isoniazid for rapid acetylator people is about 1/3 to 1/2 of that in slow acetylator, and an average half-life are less than 1 hour and 3 hours respectively. More rapid clearance of isoniazid by rapid acetylator is usually of no therapeutic consequences when appropriate doses are administered daily. Isoniazid metabolites and a small amount of unchanged drug are excreted in urine. No dose adjustment needed in renal failure patients. Isoniazid found to inhibit many cytochrome B450 enzyme. This will lead to increased concentration of phenytoin, carbamazepine, and benzodiazepine. However, when used these drugs in combination with rifampin, a potent cytochrome enzyme inducer, the concentration of this medication are usually decreased, so dose adjustment or dose increment is needed. Isoniazid used clinically in dose 5 mg per kg per day once per day, up to 10 mg per kg per day used for serious infection or if malabsorption is problem. 15 milligram per kg dose or 900 milligram may be used twice to three times weekly dosing regimen in combination with a second antituberculous agent, for example, rifampin 600 milligram. With the isoniazid, pyridoxine 25 to 50 milligram is recommended to neuropathy, which is an adverse effect of isoniazid. Isoniazid indicated also for the treatment of latent tuberculosis in dose of 300 milligram per day or 900 milligram twice weekly for 9 months. Side effect of isoniazid is related to dose and duration of administration. A. Immunological reaction can occur, which appear in forms of fever, rashes, drug-induced systemic lupus erythematosus. Number B, direct toxicity of isoniazid, which can induce hepatitis, which is a major toxic effect. This is distinct from a minor increases in liver transferase enzyme up to 3 to 4 times normal, which does not require cessation of the drug, which is seen in 10 to 20% of a patient, which can be asymptomatic. فإننا side effects hepatitis، لكن في side effect minor بتظهر وهي زيادة في الليفر امينو ترانسفيريز انزيم، ودي ما بتحتاج ان نوقف الدواء. clinical hepatitis with loss of appetite, nausea, vomiting, jaundice, and right upper quadrant pain occurring 1% of isoniazid recipients and can be fatal, particularly if a drug not discontinued promptly. The risk of hepatitis depends on the age. من السايد افكت اللي ممكن تظهر اللي هو البريفرال نيوروباثي، ودي due to انه الايزونازايد promote the excretion of pyridoxine. Again في CNS toxicity can occur, which include memory loss, psychosis, attacks, and seizures. This effect may respond to pyridoxine. في miscellaneous like hematological abnormalities, propagation of pyridoxine deficiency, anemia, tinnitus, and GIT discomfort. The second drug في first line was rifampin, semi-synthetic derivative of rifamycin, which is antibiotic produced by amyocoliposis rifamycinia, which is in past or formerly known as Streptomyces mediterraneae. It is active rifampin against gram-positive organism, some types of gram-negative organism, such as Neisseria, Haemophilus species, Mycobacterial, and Chlamydia. Mechanism of action resistant of pharmacokinetic profile of rifampin. Rifampin bind to beta subunit of bacterial DNA-dependent RNA polymerase enzyme and therefore inhibit RNA synthesis. Resistance occur from any one of several possible points of mutation in RPOB, the gene for the beta subunit of RNA polymerase. This mutation results in reduced binding of rifampin to RNA polymerase. Human RNA polymerase does not bind to rifampin and is not inhibited by it. Rifampin is bactericidal for Mycobacteria. It is readily penetrate most tissues and penetrate into alphagocytic cells. Rifampin is well absorbed after oral administration and excreted mainly through the liver into bile. Then it undergoes enterohepatic recirculation, with the bulk excreted as deacetylated metabolite in feces and a small amount excreted in the urine. Rifampin induces most cytochrome B450 isoforms, including cytochrome 1A2, 2C9, 2C19, 2D6, and 3A4. which increases the elimination of numerous other drugs including methadone, anticoagulant, cyclosporine, some anticonvulsant protease inhibitors, and contraceptive. So, co-administration of rifampin results in significantly lower serum levels of these drugs, which need to increase a dose of these drugs. Clinical use of rifampin. Number A, mycobacterial infection, rifampin 600 mg per day, administered with isoniazid or other antituberculous drug to patients with active TB to prevent an emergence of a drug-resistant mycobacteria. Rifampin 600 mg daily or twice weekly for 6 months, effective in combination with other agents in some atypical mycobacterial infection and in leprosy. Rifampin 600 mg daily for 4 months as a single drug is an alternative to isoniazid for patients with latent TB who are unable to take an isoniazid or who have had exposure to a case of active TB caused by isoniazid resistant or rifampin susceptible strains. Other indication of rifampin 600 mg twice daily for 2 days can eliminate meningococcal carriage. Rifampin 20 mg per kg maximum 600 mg once daily for 4 days, used for a prophylaxis of Haemophilus influenzae type B disease. Rifampin combined with a second agent, sometimes used to eradicate Staphylococcus carriage. Rifampin combination syrup is used for a treatment of serious staphylococcal infection such as osteomyelitis, prosthetic joint infections, and prosthetic valve endocarditis. Side effects can occur. Number 1, harmless orange color to urine, sweat, and tears. Occasional side effects include rashes, thrombocytopenia, and nephritis. Rifampin may cause cholestatic jaundice and occasional hepatitis. If administered less often than twice weekly, rifampin may cause a flu-like syndrome characterized by fever, chills, myalgias, anemias, and thrombocytopenia. The third one is the ethambutol. Ethambutol mechanism of action, it inhibits mycobacterial arabinocyte transferase enzyme involved in a polymerization reaction of arabinoglycan, which is essential component of mycobacterial cell wall. Resistant to ethambutol due to mutation resulting in an overexpression of gene coding this enzyme. Ethambutol is well absorbed and is secreted in feces and 50% in urine in unchanged form. Ethambutol accumulates in renal failure and the dose should be reduced to 3 times weekly. Ethambutol crosses the blood-brain barrier only when the meninges are inflamed and concentration in cerebrospinal fluid ranging from 4 to 64% of serum level. Ethambutol always given as a single daily dose in combination with isoniazid, rifampin, pyrazinamide during the initial intensive phase of active TB treatment. Ethambutol is also used in combination with other agents for a treatment of non-tuberculous mycobacterial infections such as Mycobacterium avium complex or Mycobacterium cannasi. Side effects of ethambutol include hypersensitivity to ethambutol. It may be rare. The most common serious side effects is retroviral neuritis, resulting in loss of visual acuity and red-green color blindness, which is those related adverse effect. The fourth one is pyrazinamide or nicotinamide drug. Mechanism of action of this drug and clinical use: pyrazinamide is converted to pyrazoic acid, which is active by a mycobacterial pyrazinamidase enzyme. which encoded by PNCA, pyrazinoic acid, then disrupt a mycobacterial cell membrane metabolism and transport functions. Resistance to pyrazinamide may be to impair uptake of pyrazinamide or mutation in a gene encoding an enzyme that impair conversion of pyrazinamide or a nicotinamide to an active form. Pyrazinamide, important from line drug use in conjunction with isoniazid rifampin in short course for 6 months regimen as sterilizing agent, active against residual intracellular organisms that may cause relapse. Tubercle bacilli develop resistance to pyrazinamide fairly readily, but there is no cross-resistance with isoniazid or other antimycobacterial drugs. Side effects: major adverse effects of pyrazinamide include hepatotoxicity, 1 to 5% in patient, nausea, vomiting, drug fever, photosensitivity, and hyperuricemia. Second line drug for TB. The alternative drug considered: number 1, in case of resistance to first line agent; number 2, in case of failure of clinical response to conventional therapy; number 3, we use a second line in case of serious treatment limiting adverse drug reaction occur from first line drugs. first drug في السكند line is streptomycin. والstreptomycin زي ما شفناه في الامينو glycoside penetrate into cell poorly and is active mainly against extracellular tubercle bacilli. The drug crosses blood-brain barrier and achieve therapeutic concentration with inflamed meninges. Streptomycin clinical use in TB. The usual dose is 15 mg per kg per day intramuscularly or intravenously daily for adults for several weeks, followed by 15 mg per kg 2 or 3 times weekly for several months. Other drugs are always given in combination to prevent an emergence of resistance. The second drug is ethionamide. Ethionamide is related to isoniazid and similarly blocked synthesis of almycolic acid, poorly water soluble and available only for oral use, metabolized by liver. The dose is 1 gram per day, is poorly tolerated because of gastric irritation and neurologic symptoms, often limiting the tolerable dose daily to 500 to 750 milligrams. Ethionamide is hepatotoxic. Neurologic symptoms may be alleviated by pyridoxine. Resistance to ethionamide as a single agent develop rapidly in vitro and in vivo. There can be low-level cross-resistance between isoniazid and ethionamides. وبالتالي ممكن إذا الزول عنده side effect من الأيزونيازايد وقفناه منه ما ممكن يحصل له cross resistance. The third one is cabromycin, which is peptide protein synthesis inhibitor, antibiotic obtained from Streptomyces cabriolis. Daily dose injection is 15 mg per kg intramuscularly. Strains of Mycobacterium tuberculosis that are resistant to streptomycin usually are susceptible to cabromycin. Cabromycin nephrotoxic or ototoxic. Tinnitus, deafness, and vestibular disturbance can occur. The injection causes significant local pain and sterile abscess may be developed. The intermittent dosing regimen may maximize the risk of toxicity. The fourth one is cycloserine, which is structural analog of D-alanine, which inhibits cell wall synthesis. The drug is widely distributed into tissues, even CNS, clear renally, and the dose should be reduced for renal failure patients. The most serious effect: peripheral neuropathy and CNS dysfunction, including depression and psychosis. These symptoms of this side effect can be alleviated by administering pyridoxine 100 mg or more per day. The fourth one is fluoroquinolones, moxifloxacin, most active against Mycobacterium tuberculosis in vitro. Level tend to be slightly more active than ciprofloxacin against Mycobacterium tuberculosis, whereas ciprofloxacin is slightly more active against atypical Mycobacteria. Fluoroquinolones are important addition to the drug available for a TB. The sixth one is linezolid, which inhibits strains of Mycobacterium tuberculosis. It achieves good intracellular concentration. Linezolid has been used in combination with other second and third line drugs to treat a patient with TB caused by multi-drug resistant strains. Side effects including bone marrow suppression and irreversible peripheral and optic neuropathy. After that, we will see the drug use in leprosy. Because of increasing a report of dapsone resistance of Mycobacterium leprae, treatment of leprosy with combination of drug is recommended. But a drug of choice for leprosy is dapsone. لكن لقوا إنه في resistance بتحصل due to for leprosy من اللي هو for dapsone. فعشان كده بقى combination of drug use is recommended. Dapsone and other sulfones, several drugs closely related to sulfonamide have been used effectively for long-term treatment of leprosy. The most widely used is dapsone, like sulfonamide, inhibit alfolate synthesis. Resistance for dapsone can emerge in large population of Mycobacterium leprae. Therefore, the combination of dapsone, rifampin, and clovazimine is recommended for initial therapy of lepromatous leprosy. Dapsone may also be used to prevent and treat pneumocystis jirovsky pneumonia في AIDS patients. Dapsone is usually well tolerated. Many patients develop some hemolysis, particularly if they have glucose 6-phosphate dehydrogenase deficiency. Methemoglobinemia is common but usually is not of clinical significance. GIT intolerance, fever, pruritus, rashes can occur. The second drug used for leprosy in combination with dapsone rifampin in dose of 600 mg daily dose is highly effective in leprosy and is given with at least one other drug to prevent the emergence of resistance. Even a dose of 600 mg per month may be beneficial in combination therapy. The third drug for leprosy is clovazimine with phenazine dye used in the treatment of multibacillary leprosy. Its mechanism of action has not been clearly established. Absorption of clovazimine from the gut is variable. So this is the third drug and last one used for a treatment of leprosy. Thank you very much